This PowerPoint will review hematologic disorders of the white blood cells. Leukemia literally means white blood. It's a malignant disease of white blood cells, and it affects all age groups. And it's actually a group of diseases, each involving a different cell line. It's an explosion, proliferation of immature blast cells in the bone marrow, lymph tissue, and spleen. These cells are young and abnormal. They can't fight infection, and they are rapidly produced. They collect in your tissues, so they collect in oral mucosa, in your anal tissue under your skin, in your sinuses, in your lungs, and they cause pain, inflammation, and of course there's infection because you can't fight off infections because your white blood cells don't work. In addition, because of the hyperplasia that exists with these blast cells in the bone marrow, the production of other normal cells is impeded, and so you can get the decreased production in red cells and in platelets as well. The cause is unknown, but viruses have been implicated. There have been genetic and immune factors studied, and also radiation and chemical exposure has been implicated. If you look at the research after big radiation exposures, after nuclear power plants and nuclear disasters, there's always an increase in leukemia. And then chemical exposure, what was the movie with Julia Roberts about Times Beach, Missouri? I can't, I'm drawing a blank right now, but anyway, a big chemical exposure in a very small town in rural Missouri, and where there was an increase in leukemia. Erin Brockovich, that was her name, and she just doggedly fought and fought and fought until she uncovered it, and sure enough, it was exposure to a toxic chemical from manufacturing there. So different classifications. There are acute leukemias and chronic leukemias. Acute lymphocytic leukemia and acute myelogenous leukemia are different diseases. ALL is common in kids. AML is common in adults over 60 and has a very poor prognosis. In terms of chronic, you have CLL and CML. In CLL, it involves T and B cells, usually in adults. CML can be seen in older adults. It can also be seen in kids too. Chronic leukemia has phases. It has an insidious phase where you have some anemia, some mild bleeding. You feel okay, but little off, maybe you can blame it on a lot of other things, and you're usually unaware of being sick. Then there's an accelerated phase, which is when it becomes acute, and that's about 3 to 5 years later, and it looks like acute leukemia. It used to be almost always fatal within 3 to 6 months after the onset of the acute phase, but there have been so many wonderful treatment advances that people are living long, healthy lives after chronic leukemia. So it's amazing, actually, the progress that's been made here, and a tremendous amount of progress has also been made in acute childhood leukemia as well. Diagnosis is a CDC with differential. The differential will show the presence of blasts. It may also show decreased red blood cells and platelets depending on how advanced the disease is in the bone marrow and how many other cell lines have been suppressed because of the proliferation of the leukemia cells. You'll have a bone marrow aspiration for definitive diagnosis. There's no way to diagnose this without cytologic examination of the bone marrow to confirm not only is there the presence of leukemia, but what kind of leukemia is present. So bone marrow aspiration will give you the definitive diagnosis. Lumbar puncture and LP will determine whether or not there is involvement of the CNS, which there often is. And then, of course, genetic testing will be done. There's a Philadelphia chromosome that's in chronic myelogenous leukemia that they test for. This picture is a diagram showing the common symptoms of leukemia. You will have severe infections, and with these infections, you will usually have a low-grade fever. You don't have enough of an immune system to mount a higher fever unless you're in the acute phase. You could also have symptoms of anemia, such as fatigue, because remember that you don't make as many red blood cells either. Sternal and rib tenderness, so the places where you have bone marrow, that these cells are overpopulating the marrow and taking over, those areas are very tender. You can have an enlarged spleen, liver, and lymph nodes because of the collection of these cells. Weakness, pallor, weight loss, because of an elevated metabolic rate. These cancer cells are just taking over. They're rapidly dividing and metabolizing, and they take up a lot of energy. You can have kidney pain. You can have kidney stones and obstruction to the flow of urine and UTIs. Headache, disorientation, especially in older adults, and other central nervous system. You can get purpura if you have issues with platelets and clotting, easy bleeding and bruising. Night sweats are common. You can have pain in your joints as well. Lymph nodes, painful lymph nodes. Just a lot of different systemic symptoms that could be a lot of other things, but put them all together and they look like leukemia. The goal of therapy is to achieve remission. And remission is defined as a bone marrow that is free to produce normally occurring cells in normal proportions without the production of blasts. It is not the same as a cure. Important to understand, remission does not equal cure. It just means that the bone marrow is working normally for now. In order to achieve remission, they use chemotherapy to eradicate the leukemic cells and induce a remission. There are different types of chemo regimens depending on the type of leukemia you have, but all of them pretty much follow the same process. First phase is induction or remission induction phase. Some people describe this as the treatment being worse than the disease. It's a very aggressive, high-dose chemotherapy, and people get very sick. It's often multiple drugs that are used. After remission is achieved, they do an intensification therapy with the same drugs at higher doses but for a much shorter period of time. And the consolidation phase ensures that all these leukemic cells are gone. Once they're gone, then you'll have maintenance chemo monthly. Radiation is sometimes used with chemotherapy in the initial treatment. You can have full body radiation or radiation just to specific areas that are affected by the leukemia. A lot of times after they achieve remission, they will treat with a bone marrow or a peripheral stem cell transplant. What happens here is they give the patient high-dose chemo and total body irradiation to prepare the marrow. They wipe out all of the malignant bone marrow. Then they either replace it with an allogenic marrow, which is from yourself, from a donor, or an autologous transplant, which is from yourself. In a Bone marrow transplant, obviously they get bone marrow. Stem cell transplants, they collect hematopoietic stem cells during remission and then reinfuse them later into the same person, or they can also use donor cells as well. I talk about bone marrow transplant in a different PowerPoint. I think it's about blood transfusions and other therapies. Something to remember when you're caring for older adults is that people over the age of 65 can require reduced doses of chemotherapeutic drugs to prevent toxicity because they have decreased renal function and decreased liver function, and so the drugs are not metabolized and excreted as quickly as in younger people. So they will give lower doses, and as a nurse you need to be aware to look for the complications of toxicity because they'll occur more frequently in older adults. The nursing diagnoses that you're going to be working with these people: risk for injury, that could be for infection, for bleeding. They're going to have fatigue and exercise intolerance, definitely impaired oral mucous membranes from the chemo and from the disease. Knowledge deficit, they won't know about any of this. There is so much for these people to learn to be able to take care of themselves, especially when they're immunosuppressed. Anxiety, very scary. Can sound like a death sentence. It isn't, but it can sound that way. And then also an alteration in nutrition because it's difficult to eat during the treatment, and these cells, as I mentioned, are rapidly metabolizing, and so you wind up losing a great deal of weight often. So a short case study here. You have a gentleman on your unit undergoing initial treatment for leukemia. You enter his room and find it full of visitors. What concerns do you have? Well, he is at risk for infection, and if he develops an infection, he will have great difficulty recovering. Multiple visitors increase the likelihood that somebody in that room will pass on some kind of an infection. They may not be aware of the risk, and honestly, neither may he may not be aware of it either. He's probably also really tired because the disease makes you tired, the treatment makes you tired, and visitors require energy. So what do? Well, you can be kind but firm and explain that while family and friends are important, the risk for infection here is very great. So no one with any symptoms should ever enter the room. Visits should be brief to prevent overtiring, and I hate to say this, but you probably ought to keep little kids out because they are really germy. And I know people want to see their children and grandchildren, but any visitation with small children needs to be monitored and to make sure those kids do not have any symptoms of anything before they come in. How can you promote patient-centered care during his treatment? Well, you can ask about his preferences and attempt to honor them if possible. Maybe he could choose 1 or 2 visitors that could come at a time and then schedule that for a time when he might be less fatigued. You can help reinforce restrictions so that he doesn't have to. You can be the bad guy here. You can also help facilitate other means of communication with family and friends. Do they have the ability to FaceTime or Skype or do some sort of group chat? Anything that you can do to make it so that he's not socially isolated, but he's not at risk for infection from the people coming in and visiting him, and also he doesn't get overtired from the visits. Multiple myeloma is basically cancer of the bone marrow. They really don't understand the etiology. Genetics, obesity, and exposures to toxic chemicals have been discussed, but nobody really knows. And what happens is the cancerous cells as in leukemia, produce very rapidly, and they infiltrate the bone tissue and produce tumors in the bone tissue. You can see in this little picture here, you've got normal cells and normal antibodies, and then you've got abnormal plasma cells and abnormal antibodies, and then those are clumping up and making tumors in the bone. The diagnosis is made with CBC. You'll have moderate to really severe anemia with increased white blood cells. You get what they call Bence-Jones proteins, or M-type proteins in the blood and in the urine. So you'll do a 24-hour urine for that. X-rays will be important for the bones, and MRI for changes in the lungs and in the bones, and of course a bone marrow biopsy will provide a definitive cytologic diagnosis. The signs and symptoms of multiple myeloma are skeletal pain, joint pain and swelling, and pathologic fractures. The pain can be a constant severe back pain or a rib pain that increases with movement. And when the bones become full of tumors and the calcium is displaced by the cancer cells, you get pathologic fractures of your long bones. You can get joint swelling and tenderness. You can get vertebral compression fractures, and this can cause cord compression and peripheral neuropathy. It can progress to a loss of bowel and bladder function, and finally to paralysis from the cord compression. This is an oncologic emergency. You also see low-grade fevers, malaise, weight loss, anemia, infections, and clotting issues due to the pancytopenia. Kidney stones and renal failure are due to the increased calcium. The calcium is displaced from the bones, put into the blood, and it can cause a hypercalcemia. You get kidney stones, and then that's followed by renal failure. So if you look down at this little acronym CRAB, it's for symptoms of an active multiple myeloma. So you have high calcium in your blood because it's moving out of the bones. You have renal or kidney problems because of the hypercalcemia. You have anemia, and you also have bone problems. You can have pain and pathologic fractures. So treatment is a two-pronged approach. You need to manage the disease and also manage the symptoms of the disease. In terms of managing the disease, corticosteroids are important, chemotherapy, and immunotherapy. Immunotherapy is really promising. I don't know if you know who Tom Brokaw is. He was a very famous news anchor for NBC. He had multiple myeloma and was basically given a death sentence, and with immunotherapy he's in remission and he's going strong. So it's really a very promising therapy for a lot of cancers, and multiple myeloma is one of them. They can also give you high-dose chemo and radiation and a stem cell transplant. Managing the symptoms, you want to monitor and treat the hypercalcemia, give them medication to decrease their serum calcium. They do radiation for bone pain to get rid of the to get rid of the tumors in the bone that are causing the pain. If you have compression of fractures of your vertebrae and those are pressing on your spinal nerves, they can do a laminectomy. Treatment for kidney stones, if indeed those do happen, and dialysis will work as well. Making sure that you treat dehydration, keep them really well hydrated. Be careful for any respiratory infections that may occur and treat those quickly. And pain. Bone pain is just really bad pain, and so making sure that you're relieving pain should be a priority goal for you. So reviewing nursing management, You want to be careful anytime you move them because of the potential for fractures. Doesn't take much of a force on one of those long bones to break it. Supportive care is important because of the many complications of the disease and of the treatment. Encourage adequate hydration, 3 to 5 liters of fluid a day. 3 to 5 liters, that is a lot of fluid, but it really helps to minimize the problems from the hypercalcemia. And again, I'll just repeat it, assess and manage the pain. Acetaminophen and nonsteroidal anti-inflammatory drugs can work, but if you use them in combination with narcotic analgesics, it will work a lot better because, as you may recall, those drugs work synergistically. And finally, if you are thinking about assignment considerations when you're taking care of somebody with multiple myeloma, really think when you're enlisting a nursing assistant to help with positioning, moving, or toileting the patient. They may not understand how prone the patient is to bruising, bleeding, or fractures. And so don't assign ambulation of the patient with multiple myeloma to assistive personnel because any slight bump, twist of the body may cause a fracture. This is one of those things that you really want to handle yourself.